my name is Holly Hertland, and I will be presenting patient monitoring systems. Our objectives are what are patient monitoring systems, examples of patient monitoring systems, what are the barriers and benefits of patient monitoring systems, and short and long-term effects. Introduction. With the use of technology, patient records, patient monitoring, and patient outcomes can be measured in the electronic medical record. Certain patient monitoring can be integrated into the EMR to collect, store, and display patient data. Data entered can be shared with all aspects of patient care areas. Electronic data entry allows for easier workflows for medical staff, identification of abnormal findings, the firing of bundles for specific disease processes, easy uploads of photo collections, and integration of telehealth and continuation of care for primary care providers. Despite the benefits, there are also barriers to electronic patient monitoring systems, and we'll go over those. What are patient monitoring systems? I found a journal that defined this pretty well. It said it was the repeated or continuous observations or measurements of the patient, his or her physiological function, and the function of life support equipment for the purpose of guiding management decisions, including when to make therapeutic interventions and assessment of those interventions. And to me, patient monitoring systems are both subjective and objective data collection from a patient to guide their medical care. Some examples of subjective are the patient history, patient interview, and objective are the physical assessment and the actual electronic monitoring. Some examples of patient monitoring systems are the EMR, glucose monitoring, vital sign monitoring, cardiac monitoring, medication administration, disease bundle alerts, photos, fall prevention monitors, and telehealth. So it was impossible for me to talk about patient monitoring systems without talking about EMRs because I think it's the most important monitoring system. The goal of U.S. healthcare was to improve quality of care while controlling costs. In 2004, President Bush proposed that all hospitals have EMRs by 2014. By computerizing health records, the United States can reduce medical errors, reduce costs, and improve care, and all areas of patient care can be interfaced. Common benefits of EMRs are to deliver guideline-based care, enhance surveillance and monitoring of diseases, reduce medication errors, eliminate poor handwriting interpretation, and it is paperless. So prior to EMRs, everything was on paper. It took a lot of manpower, a lot of time to manage patient data. There were a lot of errors made and data was missed. So the EMR really eliminates the management of paper files. This is a photo, a figure I took from the book, and I thought it was a good reflection of what EMRs do. So they reduce errors, clinical analysis, they store data for exchange and reporting, nursing care accountability, they standardize care through protocols, improve care coordination, they provide decision support, encourages evidence-based practice, automate clinical processes, measure clinical risks, improve workflows, and retain patient data. Let's talk about the patient history in the EMR. Past medical history data can be entered into the patient's medical record. This includes allergies, diagnoses, surgeries, full medical profile, advanced directive information. This information can be easily accessed by anyone entering the patient's chart at any time, and it is helpful for patient safety. If I'm trying to give a med that's on the patient's allergy medication or allergy list, it'll fire me an alert. Accurate data is necessary, so you must enter the data and it must be accurate. The assessment, the initial assessment is entered into the EMR. Also, concurrent assessments are completed with change of shift or if there's a change in patient condition. After interventions, like if you give a medication, you have a chest pain, you give nitro, you should enter a reassessment after that intervention. This can be viewed by all medical staff, so if a nurse is coming on after me, she sees that I documented clear lung sounds and now she's hearing rails or wheezes, then she can intervene. Laboratory results. These are also managed in the EMR. So the phlebotomist comes or the nurse draws the blood, goes to the lab, gets spun, and the result findings are recorded into the chart. Abnormal findings are resulted in different colors. So if it's low, it's blue. High is shown in red. Abnormal findings are reported to staff. If it's a critical finding, they'll call down and tell staff, and a comment will be placed into the medical record saying that the phlebotomist talked to the nurse about the findings. We can also view old lab results. So if I have a patient that is in renal failure, I can go back and see if this is something new for that patient or if this is chronic. Barriers, once again, efficient and proper collection is necessary for accurate results. Radiology reports. Radiology reads and films can be viewed in the EMR. Providers can look at the films. There's also a typed read by the radiologist. Any abnormal or critical findings are phoned to the physician with a comment. Overreads are done daily, so we don't have a radiologist at Penn Highlands Du Bois 24/7, so we use a virtual radiologist at night, and when our radiologist comes in the morning, he does overreads on all the virtual reads. Our mid-level providers then view all of those overreads and notify the patient if they found a discrepancy. Data sharing in the EMR, so we can use electronic communication with providers. We can also enter incident reports right from the EMR. I can look at prescription history for my patient, also integrate health data, graph trends, and measure outcomes. So now we can talk a little bit about equipment, patient monitoring equipment. So vital sign monitoring, we can monitor blood pressure, heart rate, respiratory rate, SpO2, end-tidal CO2 right into the patient's EMR. Vital signs are able to be automatically entered into the patient record. The patient needs to be attached to the monitor, of course, and this allows medical staff to pull the results into the EMR and look for trends. So I can pull vital signs over every half an hour. I start to see that my patient's getting hypotensive or getting tachycardic, and I know that we need to intervene, give some fluids, find out why the patient's getting hypotensive. They look shocky. Abnormal vital signs are also displayed in a different color in the EMR. And we also have a central station in the emergency room, so we have bedside monitors, and that's in the top picture. That's our bedside Drager monitors. So the patient's hooked to that in their room. Then at the nurse's station, there's two or three central stations, and this can be viewed by anybody in the nurse's station, the doctors, the nurses, the techs. So if there's an abnormal finding, high, low blood pressure, heart rate, that will alarm and at the central nurse's station and in the patient's room. So some barriers to this are artifact. So the nurses must have knowledge of cardiac rhythms, normal blood pressures, and those alarms must be acknowledged. So they'll keep alarming until a nurse cancels the alarm. So like I said, the top one, those are the bedside monitors. The hospital also has these portable telemetry monitors that are put on patients. So we have in the ER, if we have somebody in the hallway that needs a cardiac monitor, but we don't have a room for them, we can put them on these portable telemetry monitors and put them on our central station. Glucose monitoring, glucometer reads are automatically entered into a patient chart. Once again, easy identification of abnormal results. They're in a different color. It gives you suggestions for interventions, and we can order sets or power plans for abnormal findings. So we have a hypoglycemic order set, and it'll give you guidelines on how to manage that care. The patient must be registered for this to display. So in the ER, we get somebody critical. Sometimes we're checking their blood sugar before they even get off the EMS stretcher, before they're registered onto our tracking board or into our EMR. So then we would have to manually enter that result. Cardiac monitoring. EKGs are performed and transmitted into the patient record. This can be viewed by all medical staff and cardiology. We can view old EKGs for comparison. We also have a second provider on at all times at Penn Highlands Du Bois, and they do an overread of the EKGs, a second read. Our doctors, are very good at reading, but they make mistakes. So if they find anything abnormal, they'll call down. It's usually already known, but it's a second it's a second look at that EKG. This helps with faster treatments and interventions in the cardiac cath labs. We also have outpatient Holter monitors or King of Heart monitors if the patient would need that, and they can go home. If there's an abnormal finding, it's called to the patient and say, hey, you need to get to the ER. You just had, a lethal rhythm, or there's something going on that you need to get checked out. Can't talk about cardiac monitoring without talking about cardiac arrests. So the American Health Association guidelines were developed in 1966. These guidelines are updated based on outcome studies, early recognition and activation of CPR, defibrillation, and access to medical care have saved lives. So we have the patient on the monitor. It alarms our staff of an abnormal or lethal cardiac rhythm. This activates a response in the emergency room or in the hospital. They also have the AEDs, and these AEDs are all over the place, malls, shopping centers. They identify, you have a patient that, falls at Walmart, you can run and get the AED, hook them up. It's easy for the layperson. It runs you through exactly what you need to do. So it identifies life-threatening cardiac rhythms. It is early defibrillation. It's easy to use for the layperson and early initiation of CPR. There's also some monitors for chest compressions. I've actually never seen this, but there's other videos, but there's a little box that you can put on the patient's chest underneath your hands when you're doing chest compressions, and it tells you if you're doing adequate depth and rate compressions. You can also use capnography for adequate high quality chest compressions. Medication administration. So the patient's home medication list is entered into the EMR. If I try to give a medication during their visit that's on their medication list that interacts with that medication, it'll fire an alert for me saying, are you sure you want to give this? The alert requires an answer as to why I'm continuing to administer. So I run and talk to the doctor, said, yeah, it's fine, give it. I have to put that into the MAR. We use barcode scanning at Penn Highlands Du Bois. So we scan the patient's identification bracelet and then the medication. I can enter vital signs in that medication profile if I'm giving a hemodynamic drug. I can look at drug references when I'm giving a medication. If there's something I'm not sure what it is, I can just click a button and it gives me a whole reference of that medication. Like I said, if there's a discrepancy, I'll get it'll alert an alert will fire. This increases patient safety. Some barriers are not entering accurate medication lists, overriding alerts. So we discourage that at Penn Highlands Du Bois, and we report compliance to staff on a monthly basis. Our goal in the emergency department is to have 90% compliance with patient identification and medication scanning. Disease bundle alerts. So these alerts are used as reminders to provide guidelines for evidence-based care. So one example of this is the SIRS and sepsis alerts. So a patient has findings that meets the SIRS and sepsis criteria, it'll fire an alert for staff. It's actually a little blood drop icon, and they have to complete that task. So the task requires physician notification, and then it gives you recommendations for order set entry. So it'll give you the recommended fluid, boluses, antibiotics, the labs that you need, and it is guideline-based care. Photographs. We can take photographs with an iPad in the emergency department, and it crosses into the patient record. This can be wound documentation, assault photos, and police can obtain these photos through medical records. One big monitoring system is fall prevention monitors. So a little statistic here, 30% of patients greater than the age of 65 fall once a year, and 1 in 5 of those will suffer a serious injury. So this is technology-based fall prevention monitoring. It's the use of webcams for visual monitoring. It alerts staff before the patient falls. Benefits to this is it increases staffing on the units. You don't have to have a one-on-one sitter in the room because you're using these webcams, and it also improves fall prevention interventions. Telehealth. So telemedicine allows physicians to access information about their patient regardless of distance. This gives better access to the patient and is more convenient for the patient, so they don't have to travel to doctor's appointments. Telehealth care guidelines are, we get those from the American Telemedicine Association, Human Resources Services Administration. Images, videos, clinical data can be shared to the provider, and the patient can get education, recommendations, and receive orders from the physician. Some examples of telehealth are neurology, ID, infectious disease, radiology, mental health, their PCP, advanced ICU care, teletriage, sexual assault cases, and interpreter services. The benefits are not waiting for an appointment, more frequent encounters with the provider, and fewer hospitalizations. Easy access, you can sit at home and talk to your doctor. Cost effective, decreased exposure for medical staff. Some barriers are loss of personal one-on-one meetings, inadequate assessment of patients, and technology availability. So a lot of our geriatric population don't have FaceTime or iPhones, so it might be hard for them. I just want to touch on a few of these examples that I gave. So with the current pandemic, the COVID-19 pandemic, we've been using a ton of teletriage. So the patient has symptoms of COVID-19, they call into an iPad provider. They get a 1-800 number. It hooks them up with a provider. The provider looks at them and decides whether they can have outpatient testing or if they need to come to the ER. And it has really, saved our staff from being exposed to the COVID-19. It has been a real win for our hospital. Also, the sexual assault cases, we now are affiliated with Penn State University with telehealth for our SANE cases. So these cases are few and far between. I've been a SANE nurse since 2013, and I think I've done 9 cases. So we don't see it a lot. It's a high stress situation, so we get these expert SANE nurses that come into the room on a monitor with us and do the exam with us, collect the evidence with us, and take photos. So it's also been a huge help in our emergency department. So some benefits of patient monitoring systems. It is guidance of evidence-based care, real-time documentation and results. You don't have to worry about writing down your patient's assessment, their reassessment if there's any change. It's all done on the computer, and you can do it right in the room with the patient. It decreases workflow for medical staff. You can follow trends easily in result findings. You can compare past findings with current findings. It's been a huge patient safety reduction in medication errors and also better surveillance and monitoring. Some barriers to monitoring systems are artifact, like I said, in the vital signs, um, inaccurate data entry, not following through with your abnormal results, standardized documentation. And what I mean by that is when we first got Cerner, which is our EMR, the inpatient floors got it first before the emergency department. And it was really hard. I worked on the inpatient floor at that time, and it was really hard because you didn't see what the patient was coming in for. You had to go through all these papers. It really helped when the ER got Cerner and we were all standardized, because then everything was right there in front of you. Also overriding workflows, like I said, with the medication administration, it's the barcode is not scanning and you just click ahead. And also ineffective EMR training and education. Some short-term effects of patient monitoring systems are the real-time documentation, immediate interventions, decreasing the workflow for staff. It gives you recommendations of evidence-based care, and it is helped with patient safety. Long-term effects are the continuation of care. So the doctor can look at our look in Cerner and see everything that we did in emergency department, everything that they did on the inpatient side, and it helps them manage the chronic disease processes. Also decreases the workload for staff as far as once your past medical history is entered, your past surgical history is entered, it's always there unless you change it. And you can also graph trends in findings. A few recommendations: you have to assess your patient, so you can't just use what Cerner, what your EMR is telling you, or what the monitor is telling you at the central station, at the nurse's station. You have to go in and look at your patient. Technology has its flaws. Also, enter the data. If you go through it with your patient, enter it. When you get that patient back, if you do see him again, that data is already there, and it'll save you time in the long run. Also, if you have abnormal findings, tell somebody. Better safe than sorry, and it'll have better outcomes for your patient. In summary, technology has shaped the future of healthcare. The use of patient care monitoring allows healthcare staff to safely monitor the patient when away from the bedside. This not only increases patient safety, but also decreases workload for staff members. Although technology is a helpful tool in the daily care of our patients, it should not decrease patient interaction, satisfaction, or assessment skills. And that's all I have. Thank you.